All right, welcome everyone, and thank you so much for joining us today. My name is Glenn Beebe. I am with the Intermountain Healthcare Media Relations team. We want to thank everyone for joining us today. We are going to hear from Dr. Todd Vento. He is an infectious diseases physician with Intermountain Healthcare, and he also helped treat Mark Jorgensen, who is also joining us today. We want to thank him for being with us here as we mark, this is now the 1 year anniversary of when Utah received its first COVID-19 patient, and just going through a little bit of the treatment, how that worked, what we've learned, and what that experience has been like for patients like Mark. And so, Dr. Vento, thank you for joining us today. If you just maybe want to take us through, it's been a year now since we had our first patient. Just take us through what that was like 1 year ago today, and just kind of where we've gone from there.
Yeah, thanks, Glenn, and thanks, folks, for joining on the session today. It's actually hard to believe it's been a year. In some ways, it feels like it just happened. In other ways, it feels like it was 10 years ago. I'm sure folks can relate to that. I think getting the call from the Centers for Disease Control to say that we had a Utah resident who was in California, who had come from Japan on the cruise ship, and that they wanted to transfer him to Intermountain. I think the reality is you do prepare for those things, and we had a lot of systems in place. But when you get that call, it's not until that moment that you think, oh, wow, this is real. Like, we knew there was a pandemic going on. We had been following it. We had been doing a lot of screening of patients coming back from China and Europe. But now we have a call that says we want to have a patient who has COVID come to Utah. So I just remember that sort of startling call, but then thinking, really it would be important for me to talk to the patient. And so we were able to actually arrange a phone call while he was still in the hospital in California to talk, and just to kind of make sure he knew who we were, and so that we could make it so that it would be a smoother transition for him, given that it was still going to be a long ordeal, and think about what he had been through already, in that his wife had COVID, was taken off the ship, was in a hospital in another country. He was taken back, via State Department air, put in a military base, then put in a local hospital in California, and now he has to be transferred to another facility. I mean, just that whole process is just dizzying if you think about it. So we're able to actually make that connection, and then try to prepare for his arrival, and make that decision to actually use our environmental protection unit, or like a biocontainment unit. The reality was Mark's case was very unique at that time for us, because he has no symptoms. And so we, had to figure out, well, that's, how infectious will he be? How long will he be infectious? The nice thing is we had a lot of systems in place, like telehealth measures, where we could actually minimize the exposures to nursing staff, physicians, healthcare team. So we use telehealth to actually Zoom in multiple times a day, talk to him on camera, do our exams, and then minimize the number of individuals that would go in and out of the room. I mean, since then, the beauty of that is that, now telehealth, even though we have been doing it for a long time at Intermountain and felt very comfortable, we were able to flip the switch to use it even more so in more widespread fashion. And now there's such acceptance by providers and by patients. And now there's even congressional legislation that has been put forth to actually help, use that as a mechanism of care moving forward, and to cover it as a valuable service for patients, so that they don't have to leave their homes. So that's a, sort of a big win there, if you want to look at the positive things that can come out of a public health emergency. I'll just finish off with a few other thoughts, Glenn. This concept of what we didn't know was a lot. How long do we isolate Mark? How long do we leave him? Once he's able to now go home, does he have to stay in his home until he has a negative test? Which at the time, that was the stance. And then we realized during that process, after several weeks, we had conversations with the CDC, and they said, oh, well, actually, we now know that he's probably not transmissible, therefore he can come out of isolation. I do remember that phone call, calling him and saying, positive, waiting several days, positive, waiting several days, positive, and keep making these phone calls. And then one day saying, hey, you're free to be out of isolation. And I remember him saying, like, wait, I'm still positive. I'm like, that's right. But now the CDC has a new approach. So I think the lesson there is that we learn things, we have to change, we have to adjust. People said not to use masks. That probably set us back quite a bit. Now we know that the data is incredible for masks, and we need to use masks, and we need to accept that. But you can see when you have these steep learning curve early on, sometimes folks will interpret that as, oh, maybe you don't know what you're doing. Well, reality is we really didn't. And why is that? We had a virus that we had never heard of, never seen until December of 2019. We had to learn very quickly. To that end, we now know from great scientific studies, from pre-exposure to leaving the hospital, lots of things that we can do. In Mark's case, it was really mostly supportive care and maintaining isolation, really no specific therapeutics. Now, we have vaccines that are incredible. We just got a third vaccine a couple of days ago with J&J. Those are being pushed forth in great numbers, and that's our most important thing we need to do right now. We know all the data about masks and the places that have socially distanced and stopped gathering, and how their numbers went down. We even saw that in Utah after the mandate by the governor in pre-Thanksgiving, but then after Thanksgiving, after December, we saw our cases rise, and now we're seeing them down again. So scientific explosion of knowledge and what to do from pre-exposure, after exposure, early monoclonal antibody for outpatients to prevent admissions and severe disease, what medicines to give in the hospital to prevent going onto the ventilator, what medicines and how to use the ventilator. I just think about in 12 months what we've learned about a virus that's not just going to help treatment of patients with that virus, but with other infections and other conditions like ICU patients, and also how to help folks who have long-term complications of COVID. That's something that we didn't even anticipate. We thought, oh, virus, you're done, we're finished. And now we find out that people have months and months of symptoms. So just thinking about, that this is a terrible thing that's happened, and we've, had 500,000 deaths in the US. We certainly turning the corner in terms of numbers right now, and they look better, but we now have mutated strains that we're worried about spreading. And I think, the positive, if you can say, spin the positive part, is we've shed light on things that we maybe didn't know as well as we should have, like healthcare disparities, access to care for certain ethnic groups and frontline workers. And now we can focus even more on that. That's important. We were able to get all of our healthcare systems and the state Department of Health and all the county health departments and local health districts together and really form this incredibly integrated team throughout all of Utah, to the point where a lot of the measures that have been done in Utah have been highlighted nationally for low case fatality ratio and other population level screening. And so I think pushing forth on the vaccination, just that integration of those teams, I think was really striking to be part of, and to watch the just sheer dedication and commitment by so many individuals. And then the other thing I would say we learned was building trust with the public and saying the right messages and being honest about what we do and don't know, and then saying, this is what we don't know, but this is what we're doing about it, or this is what we hope to find out. But for now, we recommend this because this is what we do know. And sometimes that's hard. You're not going to reach everybody, but it is important to tell folks and be honest about what you do and don't know, and what we think the best thing is they can do, and tell them we'll update them regularly, and then update them regularly, and don't lose that trust as well. I will say, there's certainly been a lot of negative, that's sort of an understatement, but not just for all the patients and the families and the friends of those individuals who've, not just from people who've died, but from people who've been affected long-term, and how it's affected their work and disability and what their families have gone through, and not to forget that. And actually on the healthcare worker side, we've had, early on in the pandemic, we had healthcare workers die because of lack of proper protection and overwhelming number of cases. And even now we're still suffering the effects of the stress of the pandemic on some of our coworkers, unfortunately, who've, had depression, suicide, and you can think of all the indirect effects. I think to that end, I think it's so important that we all remember that we can't be complacent. We knew it was a marathon. We explicitly stated, not we public health, not we politicians, everyone, this is a marathon, this is a marathon. Well, marathons are 26 miles, and we're probably somewhere in the teens, 20s, who knows. Point is we don't stop the marathon at that point. You can't say, now we're going to finish the race. You have to keep running. And that may sound like a very crude metaphor or analogy, but the fact is I think when I hear things like, oh, we won't have to wear masks and we won't have to do this, the reality is we don't need to worry about that. We need to keep running the race until we hit the finish line. Don't worry about the finish line. It's going to come. But if we don't do the things to continue running, we're not going to hit the finish line. So we have to keep masking. We have to keep minimizing our gatherings and keeping socially distant, and maximize the vaccine, all the tools in our preventive toolkit. And, if we do those, we don't have to worry about the outcome. It's going to come faster. And we don't have to keep asking, when's it going to come? When's it going to come? I can tell you when it won't come. It won't come if we don't do those things. And I'm not trying to get on the soapbox here, but I think it's so important not to be complacent, because we've learned so many things. And so with that, I would just say, it's important that we keep fighting the good fight. And I think, there's a lot of hope because of all the vaccines and all the great work that's been done. And I think we can get to the finish line together.
All right.
With that, I'll turn it back to Glenn and maybe get some more important comments from Mark.
All right. Thank you so much, Dr. Vento. And now I want to bring in Mark Jorgensen. He was our first patient to be treated in Utah. And he is joining us now. Thank you so much for joining us, Mark. And Mark, tell me a little bit, maybe just go into what those first days were like when you first found out you were positive, getting transferred back to Utah, and just kind of what your life has been like for the last year, and just take us through the process that you went through as one of the first patients in Utah.
Yeah, it was a crazy time for sure. We were on the ship, my wife and I, and we were tested just kind of by accident because I'm a transplant patient, and so they knew that, and they figured they would just test my wife and me just to make sure. And ironically, she came up positive, and I was negative. So they took her off the ship, put her in a hospital in Japan. I stayed there until the State Department arranged for transportation for all the Americans to come back. And I was on that plane, and I'm sure that whole thing was a nightmare. Getting back, we sat literally for about 6 hours between the ship and the plane, mostly sitting. And we learned later, because there was a battle going on between the State Department and the CDC and the White House, and I don't know who was saying what, but some wanted us to come home, and others were saying we can't bring them into the country. And ultimately, obviously, whatever side that wanted us to come back prevailed, and they made that happen. That plane ride back was quite interesting. Everyone was packed in this cargo plane 747, and I'm sure there was some transmission going on there. In fact, I know some individuals were part of the delay too, was that they had some test results had come back, and some of those individuals, some of those Americans had tested positive, and they just didn't know what to do with them. And the ones that were symptomatic and positive, they separated on the plane, but really it was just by a curtain, and I'm sure there was a lot of transmission going on. And our friend that was with our traveling party, he got very symptomatic on the plane and was isolated. And so I'm pretty sure that's probably where I caught it, because once I was we landed in Traverse Air Force Base, and they wanted to test everyone there, and myself included. I was not really nervous about that, because I figured it was just routine. And a couple of days later, they came back and said I had tested positive, and that's kind of when the whole thing got real to me. It was just kind of a whirlwind and kind of this annoying delay for a while. But that's between my wife getting tested positive and myself. It kind of started to become real. They gave me a couple hour heads up, and I had to pack everything and be taken by ambulance to a hospital in Fairfield, California. And they obviously were not prepared for this. They had no sort of a containment situation at all. And in fact, I remember I was sitting there one night, and someone from the lab came walking by with their little tray to draw labs from everybody, and comes walking in my room, and everybody kind of freaked out and got her out of there fast. But yeah, that sat there for a couple of days, and they had talked about transferring me to Oakland, where there was better facilities, and they needed the space where I was, I guess. And I made the comment to them, hey, if I'm going to be transferred, why couldn't I be transferred somewhere home? I'm from St. George, and I was thinking hopefully I could even go there. And they said, well, we can't take you to St. George, but IMC has this amazing facility that we could take you to, and found out I was going to Salt Lake. So that was kind of one step closer to home. So I was excited. They put me on a small medical transport plane and flew me from Sacramento to, I did stay one night I left that hospital in between coming to Salt Lake. I did stay one night in Folsom, California. So they took me by ambulance up there, then put me on a plane the next day, flew to Salt Lake, went to the hospital, and I was just along for the ride. I really didn't know what was going on, what was happening, where we were going. I was taken to a small building on the campus. I didn't know really where I was, and it felt very surreal. The whole experience. It was just the police escorts and the precautions and the ambulance and the kind of the stealth way they got me into the hospital and took me in there. And like Dr. Vento said, I had talked to him in California, so he knew I was coming. So I felt like I was in good hands there, and I'd be fine. So I was glad to be coming back and felt good about it. They put me in there, and I just sat there, and like Dr. Ventel said too, I was totally asymptomatic. I had nothing. I felt just fine the whole time, and it was puzzling to me as to why all this fuss was being made about, because I felt just totally normal and didn't have anything wrong at all. But people were learning about it and wondering what this all was and what was going to happen and how contagious it was and all that. And they obviously weren't taking any precautions, or they were not taking, they were taking all precautions to make sure that this could spread as little as possible. And sat there for about 7 days, and I actually got word that someone from our ship had tested positive and was home in quarantined at his home in California. And I asked Dr. Vento, I said, if hey, would that be possible? If they're doing that now, why couldn't I go quarantine in my own home? And unbeknownst to me, that was already in the works, I guess. And I think obviously everyone realized that as this spread and more cases were found, they were not going to be able to isolate everyone like I was being isolated. That was just obviously not feasible at all. And so I took a midnight ride from Murray to St. George in an ambulance again, and with escort again, and they quarantined in my house for about 3 weeks, I guess. They wanted my wife and I to stay on different levels of our house, so I slept in the basement and she was upstairs, and they wanted us to have masks when we were in the same room and stay away from each other. So that was kind of weird and different and hard, but we made it work. And so I stayed there. Let's see, it came on March 6th, and I think it was March 17th that I got word that I had been cleared and was free to, go about normal life, such as it was at the time. And by now, of course, everything had started to shut down and close up, and so I was just one of the crowd at that point. So that's past year has been pretty uneventful, honestly. I've still continued to have no symptoms. I am wondering now. I've got a couple things going on. I don't know if it's lingering symptoms of the virus or not. I've got a memory fog that's going on that I'm hearing is a symptom of it, and I'm wondering if that's part of it. And also, I've got an eye condition. My ophthalmologist has noticed that the nerves from my eye to the brain are being kind of pinched and potentially damaged, and he's convinced that it's effect of COVID-19. And so, I may not have skated free from effects like I thought I did. But I've lived a pretty normal life. We own our own business, so I'm able to do a lot of work remotely and connect as I can, and we've been able to make that work and live life pretty normally, actually. No more or less normal than everyone else that's caught in the middle of this. And my wife came over from Japan. She actually beat me home by a couple days, and she's been fine too. And we've felt very lucky and blessed to get off as easy as we did. But like everyone said, I can't believe it's a year, but here we are.
All right.
That's where I am today.
Well, thank you so much, Mark. We really appreciate that insight. We're now going to open up to the media. If you have questions, either for Mark or for Dr. Vento, please just type them into the chat. Just say the organization you're with and your question, and we'll get those read off. One of our first questions, Dr. Vento, comes from Tanya Dean with KSL. She asks, 1 year ago, did you anticipate we would be where we are today? Are we further along than you thought or not? She also is asking whether or not did we have more or less cases in Utah than you anticipated?
Yeah, early on, I'll be honest, I did not think we would be dealing with this at the to the extent that we are a year out, and that was obviously short-sighted. I think part of that's because we had a new virus. We've had respiratory virus pandemics or epidemics in the past, and I have done that as a living previously with the Department of Defense for helping with pandemics in other countries or epidemics in other countries. And so my sense was that we would be able to put forth the concerted effort to actually get pretty good control over several months. It was my initial honest thought. And then as I started seeing the cases rising in the month, 2 months, 3 months, I thought, oh, yeah. And even by late spring, early summer, that's when I started thinking COVID's going to be here for many years, probably. It's some smoldering level, and we'll probably have to get a vaccine to kind of keep it just like we did for, say, H1N1 pandemic strain in 2009, which folks called swine flu, but it's called PDM 2009. So I started thinking, well, we're probably going to be like that now. So I honestly didn't think that I wasn't thinking that it would be that intense into, say, late summer and fall, sort of naively thinking that we'd be able to get under control. But the virus has really shown us that, like we have said before, it makes the timeline. It decides what to do, and then we have to adjust. The other comment regarding trying to make sure I address the second comment too. Glenn, can you remind me the second? Was there a second part of the question?
Yeah, it was. Do we have
cases for
more?
Utah.
Do we have more or less cases in Utah
Yeah,
than you anticipated?
Actually, early on, a lot of us were looking at, and I looked at sort of the population density for New York and how that went. I had colleagues in Italy where they got overrun, and I talked to them about what they were experiencing and the measures they did and how it took off. And I was looking at the population on the Wasatch Front and how we're distributed and disseminated, and I thought, well, okay, we're not going to have the same exact situation as, say, major cities in Europe or New York City, et cetera. So we, that was enough to make us feel a little more comfortable that we'll be able to spread it out over space and time. And that's really what was important, so that we wouldn't overwhelm our hospitals up front. And if you notice, we never did overwhelm our hospitals up front, but also we had a shutdown. And so that obviously shut down literally a lot of the cases. So yeah, I didn't think that we were going to have some of the issues that we had with other places. I did get concerned on second, third surge that we were doing the roller coaster ride where, we weren't necessarily being consistent at a high level of all of our mitigation measures, and really going forth and, say, push forth on the aggressiveness with masks and distancing after the coming out of the shutdown as we came into the fall, and knowing that if we kept doing that we would start to see hospital cases rise. And I think that's when we really hit a peak in October in terms of concerns that if we don't do something more disciplined fashion across the whole population, we're just not going to be able to handle this as a healthcare system. And so that certainly we were anticipating. And I think really after Thanksgiving, after Christmas, I think we weathered the storm for now, and was grateful that we didn't really get to the point where we had to go to sort of like crisis standards of care for the entire state.
All right, thank you. Wendy Leonard from the Deseret News has a question for Mark. You once mentioned that you receive a lot of threats at your home when this first began. Were you afraid from that, and how did that impact your lives for you and your wife?
It was obviously unsettling to hear about that. I never received any directly. I mean, no one sent me any messages or anything threatening me. I heard them secondhand. In fact, the IHC team came in. It said that they had seen some on social media in various places. People from St. George had told me that there had been some feedback on some of their media about me coming home, and so I only knew about them secondhand. It was unsettling and a little bit nerve-wracking because you never think such things would never be the target of such things, but I don't know that I was ever really nervous or scared. And we got home. The local law enforcement told us to keep the number on speed dial, and if anything ever happened, to let them know immediately. And nothing ever did. So we were a little bit uneasy for a few days, but it was fine.
And Alex also has a question for you, Mark. Have you since received any of the coronavirus vaccines? If so, which one? And if not, then when do you plan to?
I have not. I don't know that I fit the demo yet. I probably could get it because of my condition, but I have not received a vaccine yet. Don't know when I anticipate getting it.
Do you plan to get one?
I'm one of those that I'd kind of like to see how it plays out, honestly. But I don't know. I'll probably follow the advice of my doctors, and he's wanting me to, so I wouldn't be surprised if I did.
And then
I would say definitively I would at this point, though.
And then we have another question from Chris Reed with St. George News. He said that when he talked to you back then when you were first infected, that you were always active, and that especially Jerry on her bike. Are you still able to be active now? And are you or your wife exhibiting any symptoms?
We're exhibiting no symptoms at all. We are very active. In fact, I just came off a ride right now, and my wife took a little tumble and we got a little bit lost. So I was kind of nervous about making this actually, but we found our way back, and she's sore but fine. And yeah, we've been out riding a lot and staying very active since in the last year.
And then Wendy Leonard had another follow-up question for you, Mark. She just wanted to ask, what do you think of COVID-19? Do you at all regret taking the cruise, and will you do it again?
I don't live life that way. I did what I did, and this is what happened. And stuff happens in life, so I don't regret going at all. We had a great time, and we had a little side adventure afterwards. And okay, and it was what it was. And yes, I definitely plan to cruise again. I'm actually in Costa Rica right now, so this is our first out international travel since all of this. So obviously we're not letting any fear of that stop us, because that's just kind of our philosophy of life.
Great. And then this one's for Dr. Vento from Alex. What have you learned about the variants to this point?
Yeah, quite a bit. And again, with everything with regard to COVID, it's always a steep learning curve. But that's the good thing is we're a lot more aware of the things that we didn't know and how to be more aggressive with that. So, we're now looking at multiple strains that have had some mutations. Some of them are very similar to one another. So the big one that we first thought about was the UK strain. And we do know that it is right now more transmissible, so it can be spread more easily to others. And there's probably some data so far that suggests that it might be a little bit more virulent, might cause some more severe disease, but just a touch. And so, so what we do know is that right now, while there may be some decreased activity from some of our therapies like monoclonal antibodies or the vaccine in terms of the level of neutralizing antibody that someone would make against that strain, the reality is they're still at levels that will handle that strain. But that said, probably not as good at handling the South Africa strain. We know less about the Brazil strain, which also went to Japan and now is another strain. And now we have California and New York strains that are similar to some of the other strains as well. Sorry, I'm going to try to lose you. So what we're learning quickly is what therapies are going to work and how we've had to adapt them. So we've already made some adaptations in how we use monoclonal antibodies early in infection. And so similar to what the former president received with Regeneron, which is 2 monoclonal antibodies, if we have concerns about having other variants, then we're looking at using 2 monoclonals instead of 1 monoclonal antibody, because there's been data from South Africa that shows that the response with a single monoclonal antibody to that strain was less effective. So far, the vaccines do work. And the reality is, it really gets back to the simple principle. The more the virus grows, spreads, bounces around from one person to another, which we all know what activities do that, the more chances it has to replicate and to mutate And those mutations are often to its advantage because they can then sustain, the virus can sustain itself in a community. And the more that happens, the more mutations happen. And the more mutations happen, the more likelihood there is that one of those mutations will eventually be, say, not susceptible to the vaccines or not susceptible to our therapies. So that gets really back to the whole first point, is that we really need to continue doing the things that work: masking, social distancing, limiting gatherings, and really get the vaccine. And the more vaccines we can get into folks as soon as possible, then we'll shut down the replication of many of the strains. Certainly the one that has been circulating for the past year or so, but also even some of the other variant strains, so that then they don't have the chance to then make new variants. That's really the concept. So it's so important for folks to really still stay aggressive until we can get to a level where we feel like, look, this is background kind of noise level, and we can continue to do, say, periodic vaccinations against COVID, just like we do for annual flu.
And Dr. Vendo, tell me a little bit about this specialized isolation unit where Mark was first treated, and just what makes this so unique.
Yeah, so it was actually, as you can imagine, was actually built, or the concept came out of the Ebola epidemic in West Africa in 2014, when we had a few cases come back to the United States. We had this couple of cases. We had a case come back to Dallas, and we had a couple nurses who got infected, mostly because of transmission from patient to care provider in the hospital. And so the thought was, we really need to have a regional asset that can contain something like a hemorrhagic virus like Ebola or Lassa fever, Lassa virus. Those are the kinds of things that we worried about. But certainly because of the unique environmental features of the unit in terms of negative pressure and controlling for isolation, so many layers of isolation measures from an environmental design standpoint, and also a trained staff on how to go in and out of an isolation room. And it's not necessarily rocket science, but it requires meticulous detail by every team member to know exactly how to behave and handle themselves every single moment that they're in the isolation unit, so that we can contain disease. And so because we had that, and because our folks were very well trained, I remember the leadership had approached me and we discussed, should we put them in the ICU? Should we put them in the hospital? Should we put them in the containment unit? And I thought, well, we have one patient and we have a containment unit and we have a team that knows how to do that. And then we brought on other team members who had been trained and to rotate the shifts. And so it seemed a natural course, but just like Mark had mentioned, it's not something that we obviously would have sustained for 2, 3, 4 patients. And but I think it was the right thing to do early on, even though it was probably made more of a little bit of a show, not intended, for Mark. And I can't say that we can take responsibility for the police escorts and all that, but I think it was trying to be really cautious. So that's why we did that. But now we've learned so much that we realize we know how to control it within regular confines of the hospital.
Dr. Vendo, we have another question for you from Lauren from ABC4. She says, do you think that COVID is here to stay, or is it a one and done virus?
I think it's probably here to stay. I don't think it's here to stay necessarily how it's been here so far. I think we've already looked at the last 2 months. Our decline has been significant in terms of cases, hospitalizations, even deaths. Now, in the last 3 to 5 days, we've seen some plateauing for the country. We're plateaued around 70,000 cases. And so I think the concern is that, are we plateauing because we're not doing things we did 2 months ago, or are we plateauing because there's sustained transmission of newer strains? And there's some evidence right now that that's probably what's happening, especially like New York, California, with the different variants. And so for that reason, I think the reality is it's probably here to stay, but that shouldn't be a fear statement or a fear-inducing statement, because we have vaccines, and we even have vaccines now with the mRNA platforms that are already being modified to address new variants. And that's really what was touted from the beginning last spring, where we said, look, we'll have a platform that we can change the structure. And very, very similar to the concept, not the exact scientific mechanisms, but the concept of flu, where we look and say, okay, which strains are out there each year, right? And then we put forth a new vaccine strain that has 4 strains covered for flu each year. And we say we take a sort of make our best estimate on what's circulating in the Southern Hemisphere, the Northern Hemisphere, say this is the vaccine combination that we think should stop the flu strains that'll circulate. Well, same thing will probably happen with COVID, where it's still here, get many people vaccinated, get many people still behaving with the good preventive measures until we get the virus so low that it doesn't replicate and mutate, and then we continue to vaccinate folks against having it show up again, to the point where we essentially get it to a level that I would love to see go away, but I don't know that it's realistic. And it is a coronavirus, and we've had other coronaviruses that circulate. They just don't cause SARS level conditions. And I will say, last comment is SARS-2 is so much different than SARS-1 and MERS-CoV, which were also coronaviruses, because they were somewhat of one and done. And they just behaved differently. They weren't the exact same virus. They had different fatality rates. They had different transmissions. Some of them actually did not spread when people were asymptomatic. And so that's the other danger, is that when you have people spreading virus when they don't have symptoms, much, much harder to control that virus over time.
And we have a question from Chris Reed. He asks, how did treating Mark set the tone for COVID patients that came afterwards? And if a person came in now with the same asymptomatic symptoms Mark did, what would happen to them now?
Yeah, I think the setting of the tone came in really how to approach the healthcare system, what the healthcare system's approach would be to an individual patient and population. So, we give credit to Mark, we didn't intend to make him the guinea pig, but we had to learn from what happened and realize, listen, we're not going to be able to do this from the next 1, 2, 3, 4, 5 patients that come back in and get the containment unit up and all that. And so I think that really, we had already been working on pandemic planning measures and implementing them, but I think that made us start to look even more closely at, okay, let's look at, do we make those wards COVID wards? Do we make that ICU an ICU COVID ICU? And that way we get better containment, not just for individual patients, but for whole groups of patients. And so that healthcare providers approach that unit as, hey, everyone's got COVID, so I'm going to be in this protective posture the entire time. So I think that was probably the biggest thing that came out of that. In terms of what we know about asymptomatic patients now, which is a ton, we really can isolate for a certain amount of period. Really, it's really 8 to 10 days, but from the moment of first test recognition, just like if you have a mild case of COVID and don't go to the hospital, we isolate those individuals for 10 days as long as they don't have a fever for 24 hours and they are improving, but they can still have symptoms, but they're now not felt to be infectious. They may still have the virus show up, the molecular remnants, the genetic remnants of the virus, but it doesn't transmit to others. And that was sort of the big breakthrough. And unfortunately, Mark had to live through it. With waiting, we were doing the whole everyday testing, and then not only that, the tests were going to the CDC, and we were waiting. And I'd get these phone calls, hey, Dr. Vento, any word from the CDC? And I thought, yeah, I would like to know myself. And I thought, this cannot go on for 50, 60 days. And I think, we were probably 40 days positive virus-ish, but not infectious to others. And we had to learn that. And so, knowing now that we don't have to test and test and test to show that it's negative to say that the person is not infectious. That's what we learned. And so we would just have that new asymptomatic patient not have to go through all that testing.
Reed has another follow-up question. Just, what have your thoughts been to seeing the pandemic progress here in Utah? And, after Mark was first treated here, just how that progressed, and just any thoughts on how things like mask wearing and social distancing, et cetera, kind of became political and stuff as this went on.
I think that's a big learning point. I'd say if you would have asked me, what other things did you not expect? And again, not from being naive, but from being hopeful and having worked in public health and infectious disease and worked in epidemics before, thinking that, hey, this is the advice, this is what we know, this is what we don't know. But I think this concept of, trying to be better at addressing misinformation and disinformation, and also trying to communicate to let folks know. I know we all want to have the answers like that. I mean, as physicians and public health scientists, we absolutely want to know that, because we don't want to have to go through all of the pain and suffering that's going to happen if we don't fix or learn those things early on. And I think when we had all those cases in New York, and we had quick spread, and we had cases in Washington State where it went through long-term care facilities, and we had several deaths, and that system was really suffering. But we learned a lot, because we would talk to colleagues in University of Washington, and they would say, look, you got to do this, you got to do this. And we didn't even know that from the CDC, WHO. We knew it from colleagues that we happened to just work with before in the infectious disease community. So I think, it's unfortunate that that we had to say, look, let's not recommend masks because we got to save the masks. But we didn't know at the time that, well, how about face coverings? How about 2 layers? How about 3 layers? And if you look back, you can see Dr. Fauci and others on the task force saying like, hey, we don't think you need to wear a mask, because we really didn't want to have all of the healthcare workers run out of masks and get all the healthcare system infected, and then those individuals not be able to provide care for the next wave of cases. So, I think that was probably one of the biggest early lessons learned, that we really, my personal stance, and this is mostly from being working in the Army, is, get out in front of the message every single day and say, look, here's what we think, here's what we don't know, and then do that every day so that there can be updates, and so folks will be aware that as soon as we make a change and they understand, look, that those people have been communicating with us regularly, and they've told us what they don't know, and they told us what they know, and they told us exactly when they found out. That to me helps build trust. And then when we say, now, you know what, you've got to wear a mask. We've got enough data, you got to wear a mask. Instead of, maybe thinking like, wait a minute, you told me no mask. But I think creating that continued established trust. And then the reason why that's important is because we did a lot of roller coaster riding. The virus made its own roller coaster, but we made another roller coaster on top of that. We're like, hey, we're doing better. Oh, we don't have to mask anymore. Let's stop masking this place. Then what happened? Infections. Oh, we got a mask again. That for prevention doesn't work. We have to have a solid system of all the preventive measures, and then watch what happens to the virus, and don't react quickly to say, oh, good, now we can stop. We're not going to stop. Again, it's like stopping the marathon at the 20th mile. You don't finish the marathon. So again, it sounds like beating a dead horse, but really that's the important thing, is we can't be doing this reactive approach. We have to be consistent in that message of prevention.
And Chris has another question for you, Dr. Vento. Mark had mentioned long hauler symptoms like memory fog. Has long hauler symptoms been more common in people who are asymptomatic? And what needs to be done for long haulers that we aren't doing?
Yeah, it's a good question. And there's a lot of research going on through many different groups. There's several groups out of New York, now exploding sort of all over the country. And they're actually now collaborating on what they're seeing. What I've seen so far in what literature I've read on long haulers is that they felt it was more likely to happen in individuals who had had a symptomatic infection than not having a symptomatic infection. Just like we've seen people make antibodies more likely if they've had a symptomatic or more robust or severe COVID infection, they're more likely to make the antibody. But that said, asymptomatic patients have also had antibody production. We haven't seen as much long-term COVID or long hauler syndrome with the COVID sustained complications in asymptomatic individuals. But there have been patients who will say, hey, now I have this, now I have that, and that's being looked at right now. So we don't have as much information about that as we do. And you can imagine that makes sense, because like, oh, you were in the ICU. Hey, I want to see what happens to you over the next 3 months, versus you're asymptomatic, and we don't continue to watch folks, but they may come back and say, hey, I'm starting to developing something that I think might relate from before. And that's when we start to learn more about that.
Great. And Mark, one last question for you from Chris Reed again. He just also kind of wants to know your thoughts on how things have progressed in the pandemic after your experience. Obviously there was a lot of unknowns, but just how you've seen things progress, and what are your thoughts on that?
I honestly don't know how to answer that. I'm just like everyone else. I just kind of watch what happens and get what news I do. And I'll admit, I'm kind of in that camp that scratches my head with different information that comes out, and don't know what's what and who to believe and all that. But I'm kind of in the same camp as Dr. Vento. I had no idea we would still be doing this a year later. That really surprised me when this first flared up. Everyone was warning me and said something. I expected it to be another swine flu or bird flu, and all these annual scares we seem to have from different flus coming. And I'm very surprised it lasted as long as it was and has been severe as it was.
All right. All right, and I'm not seeing any more questions from the media, so that will conclude our press event for today. I want to thank Mark and Dr. Vento for joining us today and just giving your thoughts on this. And for members of the media, we will be sending out a recording of this press event along with some video of our special unit that Dr. Vento had mentioned, where Mark was first treated. And we will also have some pictures that Mark has supplied from just kind of his journey of what happened. We want to thank you all for joining us today, and we hope you enjoy the